So what I'm going to talk about is just integrative care. For some of you, this is old news. For others, this will hopefully be informative. Integrative care is the systematic coordination of physical and behavioral care. So really, especially when we're looking at the idea of co-location, it'll allow patients to feel like they've come to the right place. That, this is somewhere that can take care of the majority of their needs. Most physical health needs as well as most mental health needs. And then it avoids the fragmented approach that's really been a problem. Part of my role is getting to know people in the community and getting to know the different organizations in the community. And I'm always impressed with, I'll go to a primary doc office and, they talk to me about how they've got a lot of behavioral health problems, but they don't really know who in the community they can refer to. Then I'll, talk to, especially the more independent mental health providers, and they say, well, most of our referrals are self-generated. We're not getting a whole lot from primary care physicians' offices. So it seems like this is rather ripe ground to cultivate. So just some statistics. 70% of the visits to primary care providers involve psychosocial factors. Primary care providers are the de facto mental health and addiction disorder providers for 70% of the population. A lot of primary care providers kind of instinctually want to refer these patients somewhere, but given the limited resources, especially historically limited resources, they've had to treat those in-house. And so we're hoping there's a better way to facilitate that interaction. 80% of patients with depression go to their primary care provider first. I always tell primary care providers, I'm a psychiatrist, but you treat much more depression than I do. Most psychiatric treatments are delivered by primary care. An increasing number of primary care providers have become experienced and skilled in the use of psychotropics. That's different than being comfortable. That's also different than having the desire to use these medications. That really we would like to have some specialization, some support in those areas, make everybody more comfortable. 67% of psychoactive agents are prescribed by the PCP. When I talk to most PCPs, they're really relatively okay with this, as long as there's some mental health support. But most of them, or a lot of them, aren't finding that. 80% of antidepressants are prescribed by a PCP. And that's not all that surprising to any of us. And then 92% of elderly patients receive mental health care from their PCP. Now that's rather striking, that we have such a dearth of resources for our elderly and geriatric populations that we can't get that specialized care. But that's something that we can work on. So, this is something that benefits both sides. Of course we want to treat the independent psychiatric illness, but it doesn't exist in a vacuum. Psychiatric disorders affect the way that we function and affect the way that we respond to physical symptoms and physical disorders. I think the one that most of us are familiar with is chronic pain. There's almost always a psychiatric component to that. But there's also psychiatric components to diabetes, anxiety, respiratory symptoms with anxiety, coronary artery disease, cardiological problems. So, I apologize to football fans. This is TiVo, but I thought it was a good picture of a handoff. So, this is really the important part. Now, when somebody's co-located, the ideal is that they can walk the patient down the hall, introduce them to the to the mental health provider, and that patient is nicely tied in. But we can use those same tools and techniques, when it comes to, giving a phone call up to a mental health provider that we're now familiar with. So the basic components to prep and introduce the patient to the concepts and goals. Why am I making this referral? Miss Johnson, I'm worried that you're depressed, and you've told me that you're crying most nights. I'd like for you to see somebody that specializes in this, and they'll work with you through a psychotherapeutic perspective of helping you understand what's going on and giving you some support to make this time in your life easier for you. So if you are in the same office, then you're able to just excuse yourself and walk down the hall. But the same thing can be done by calling up your colleague and saying, you know, this is Miss Johnson, and I'm worried about her for these reasons, and I'm hoping that you can follow up with her care. If you've done some screening, that's even better. You've got a tangible number, you've got a tangible net measure that you can communicate to the mental health provider that's picking up the handoff. So, if you did a screen result, then you can send that along to the mental health provider. That gives them a nice starting point. You know, again, a lot of times when somebody is referred, they get cold feet. They think, actually, nothing's really wrong with me. And it's like, well, this is nice to say, you know, you scored pretty high on this depression inventory. And so, why don't we start talking about what's bothering you with regard to depression? So, if you're in the same office, being able, for the mental health provider to be able to go into the exam room can be very helpful. You can actually see what the patient's experiencing at that particular time. And that includes, maybe it's just anxiety with the exam itself. You know, but usually it's something deeper than that, and it's a great place to start that therapeutic relationship. And then, when you have that flexibility, when you have, you know, that interaction going on, it's a lot more likely that that patient's going to return. So, when we're talking about a co-located office, about 80% of patients are going to return. You know, as opposed to just calling out and making an appointment for somebody, where about 40% of patients are going to follow up with that. And this is something I'll get to in just a moment, but same-day visits are reimbursed. So we tried to identify just a few of the major myths and misconceptions that may be preventing some of this collaboration. One of the first is confidentiality. And whenever I talk about HIPAA, this is the face people make. You know, it is incredibly complicated, incredibly long, but the basics are really simple. You know, and the short of it is, if you get a release of information, you can communicate to another provider. You know, and that is a general release of information. There doesn't have to be anything special about it. One of the more stringent guidelines is for substance abuse. And even though it's called 42 CFR, is incredibly complicated and long, basically what it says is if you have a release, you can talk to another provider. So, you know, if you're referring somebody, get a release, give a call to the mental health provider. That's what you need. So, if this is somebody that's employed with your organization, in other words, the PCMP and the mental health provider are both employed by the same entity, then you won't really need a release of information. That kind of makes sense. You know? But where it becomes a little more complicated is if you're contracting with an independent provider. So they may be in your office, but they actually work for another organization. But again, all you need is a basic release of information. If you're making a referral for continuity of care, you know, do you still need a release of information? And the real answer is, no, you don't. But the practical answer is, I'd probably get one anyway. If you're doing a medication reconciliation, do you need a release of information? And because HIPAA is set up for the portability of care, you know, that you really don't have to have a release for that. That being said, it's still probably a good idea. Okay, so then it takes time. It does take a little extra time to have somebody fill out a release of information. You got it there in your office. We're talking seconds, not minutes. It takes a little extra time to have that discussion. But again, we're not talking about a whole lot of time. It's not that much different than any other referral that you make out of a primary care doctor's office. And then this comes up a fair amount. I don't want to discuss this here. I'm just kind of dispensing some information, but I've been assured that medical and behavioral services can be billed on the same day.